to YouTube. Hurry back. There we go. And let's go ahead and start Instagram. All right, guys, let me turn myself up a little bit. Okay, so let's see here. Let me pull this down. So welcome back. I have tried to rearrange my cameras. Each day I'm getting better. I'm growing and learning. And so we're going on YouTube right now. We're also going on and then I have Instagram up here. So hopefully I won't have to be doing all this switcheroo. And so we're here now. So today, guys, I know yesterday I said that I was going to do standard, go over section 6 and 7. Today, I'm only going to go over 6. You probably can tell by the title. I'm only going to go over 6. Here's the reason why. I got some things to do today, and so I don't have as much time as I did yesterday, but we're going to get through it. We're on 6. We're making our way through it. And so today we're going to be talking about glycemic targets, okay? Now, I feel like I keep saying the same thing as far as we should be reading the standards. In a perfect world, we should be reading the standards. But at least pull the ones that are particular or specific to your demographic. But it seems like so far, all of these are like across the board pretty much for everyone, you know. And so this one is not a very long standard. It is called Glycemic Targets. And so we'll get right into it, okay? Now, I will say this. There were some slight changes, not too much, really, honestly. It was more of a, they kind of expounded upon last year's information. And I'm kind of seeing that theme. There's not a whole bunch of like brand new things that we have to adhere to. It's almost like I'm seeing with each standard, with the exception of like a couple of things, they're just giving us a little bit more information, giving us a little bit more guidance on what was stated last year, just a building upon of our information. And so out the gate, it talks about our assessment of glycemic control. One of the things that you have to be, this is something that I think that we already know, you know, but it actually outlines it here for us when to go about assessing glycemic control. And it does outline how you would measure glycemic control. So it says it's assessed through the A1c measurement, continuous glucose monitoring, using either the time in range and or the glucose management indicator, and blood glucose monitoring. So these are like the ways that you can assess if somebody is in control, their sugars are in control. They're giving you these options. Now, the slight difference this year from last year, it said that it just stated CGM, continuous glucose monitoring. But I noticed that they got a little bit more specific by you, because if you're not familiar with like a printout for a CGM, you get a lot of information. You get graphs, you get percentages, and they're actually telling us what we should be focusing on that report, whether it be the time and range, which it is on the printout, or the glucose management indicator, the GMI. So these are the things that they're telling us you should be you need to be focused on. Last year it was CGM. Well, there's a lot on that printout, so they kind of defined that for us this year. Something that we already know, they say basically that if a person is within range, their glycemic status is within normal limits, that you can monitor them twice a year. So every 6 months, if that's what you would like. If a person is still needing to meet goals, or you're recently changing something, then they suggest that you, okay, I think I'm back now on Instagram. Sorry. But what I was saying is that if a patient is not at goal if you have recently made a change to someone's treatment plan, then you need to monitor them quarterly. So every 3 months, so we kind of know that, right? And moving on, we've talked a little bit about this. We talked about, and they kind of outlined this, they do outline it a little bit more, your A1c limitations, talking about that there is a limitation with the A1c, so that if a person, let's say, for instance, you have someone that's on a CGM, and let's say that you're getting other measures and they're not lining up, you can start to suspect that there's some type of hemoglobin variant. And that is what they're outlining here. We talked about that in previous lives that I did, what those hemoglobinopathies can be that will skew that A1c. But anything that will affect the hemoglobin molecule will skew that A1c. And so they basically give you a chart, which I like, because especially working in the field, sometimes I do point of care testing. A lot of times I do point of care testing. And that's how I can tell if my meter is faulty or not, is if I'm looking at the patients, like their readings versus what I'm getting, because that's all I get. The doctor, their PCP actually gets plasma, from like plasma blood values. But I get point of care. And so this is how I can kind of, when I start seeing things don't add up, I start to ask questions. And that's basically what they're saying, is that, everything should line up. And the reason why I like this chart is because it tells us what the estimated average glucose is off the A1c. So typically, I tell people to memorize 7, the A1c of 7. On average, you're going to get about 151. Like if they were to prick their finger, if they're running around that, then they're probably at a 7%. And of course, it gives you like a full range. So 7 would be, well, they used to last year. They don't do, oh yeah, they do it right here. It's between 123 and 185. So if they're running anywhere between that, if you pull their averages, and you can tell if that's what they're running, you know what I'm saying? Or it's just a good troubleshooting tool as well. So they talk a lot about the correlation between the blood glucose monitoring and the A1c. Something that's very exciting that is not new. It's not new, but I don't know how widely known it is. It's just like the differences, the A1c differences with ethnic groups. And it states here that there is no significant difference between racial and ethnic groups. And they highlight a study that looked at non-Hispanic whites versus African and African Americans, and they did not see a difference. Now, they do state that this was not this study was underpowered, and that they didn't have a full study, and it goes into the reason why, but they can make the conclusion that, like, you can't make the blanket statement that Black people or anyone from a Black community has higher A1Cs. So we can't just lean on they're Black, they're going to have a higher A1C. No, there is a reason behind it. It's not a culture. It's not a cultural or ethnic thing. There are other factors that make certain groups more at risk. It's not, I'm Black, I'm automatically going to have diabetes. No, it's not that. You know what I'm saying? Because we see just as many white people with diabetes, or just as many Hispanic people. There are reasons why we have priority groups, and it's not just because it's not race. So basically, that's what you can get from that section, is that, and what we have seen in the past, there have been blanket statements that have been made, like, well, this group is gonna, they're more at risk. Well, there is a reason why they're at risk, and it's not race. Okay, it's more of cultural things that are behind the scenes, way of life, SDOH. There's a lot of other factors. So you just can't look at a Black person and just say, okay, I'm going to screen all Black people for diabetes. No, you need to screen white people for diabetes. You need to screen everybody for diabetes. That's basically what they're trying to say here. And a good little point that they brought up is that, in contrast, a recent report showed that Afro-Caribbeans were found to have lower A1Cs. There was a recent report. Now, if you do not know, what Afro-Caribbean is. It's not, I wouldn't say this is like a proper term, it's not an offensive term, but like, just so you understand, like when you are dealing with the Black community, every Black community, we cannot look at them through an American lens. And I will talk about this a lot more next month in Black History Month. But Black communities are across a diaspora, okay? So I think as Americans, we can think of Black people very monolithically, but you have Black people who have never set foot in this world, that have never set foot in America. You know what I'm saying? And so Afro-Caribbean people, you might have heard them, Afro-Latino people. These are, groups of people that have a lot of Latin influence. Some with Caribbeans, I think like you would include that. That's Jamaican. That would also be like Trinidad and Tobago. Afro-Caribbean and Afro-Latino populations, they're actually separate in some cases. And so it's just another subset of the bigger collective of the Black community, if that makes sense. I hope that makes sense. But, the big point I want to take away here is that we cannot view like certain groups, and we're, as Black people, we're not the only diaspora community. The Asian population, they're also a diaspora community. There's many populations in the world that, would be considered this. And like I said, we'll talk more about this next month. But when one of the diaspora communities are Black people. And just because they're Black does not mean that they have the shared experience. Everybody has the shared experience. And that's really your takeaway point there. One of the things that I noticed, and I'm not going to go into it now, because this is really kind of high level, and it's not Instagram, LinkedIn, YouTube. These are not places where we would discuss this. This is something that needs to be like a sit down kind of class, and something that somebody who is actually interested in going through would need to go through. But it does go through a lot of like CGMs and like dissecting the report. One thing that I noticed this year that they did, that they did not do last year, and I'll show you, when you pull a CGM report, it looks similar. They're giving you charts. I'm trying to show you here to LinkedIn and YouTube. They're giving you what the report, because you get a printout. You'll grab a printout, and you gotta know what you're looking at. You get all these graphs and all this data, but you gotta know what you're looking at. You know what I'm saying? And so they kind of give you what your report looked like. Last year, they didn't show all of this. They showed the AGP report last year, and this is where you would look at the time and range. So that was one of the things that they were saying. This is how you would show glycemic control, by looking at one of these measures. So that's part of the report that you would pay attention to. So I did notice that they get into the glycemic goals, and there wasn't a big change. One of the big things that they do talk about, that these goals have to be individualized. You can't just be everybody needs to be under 7. That's not everybody's goal. Everybody can't get to 7 because of comorbidities, because of their age. Some people, if they get under 7, because they have had hyperglycemia so long, their bodies, they will start exhibiting signs of hypoglycemia. And there are groups of people that are more at risk for hypoglycemia. Again, has nothing to do with race. I can tell you right now, the elderly population, very at risk for hypoglycemia. If a person is on something like a sulfonylurea or a meglitide or insulin, a medicine that elicits, insulin release, that puts them more at risk for hypoglycemia if they don't have something, some carbs on board. And so, it's not safe for everyone to get under 7, basically. And so they actually give you a chart, which this chart was in last year's standard right here. This chart tells you how to approach individualizing glycemic targets, and it goes through the disease duration. These are the things you should consider when you start thinking about individualizing the goal, the target. We don't really like language, people. Remember, you're going to hear me really try to correct language. I'm correcting myself because it is a mind shift. And then, so also, I'm also trying to help you all be up to date with what the language, the current language is as well. Saying goals, this is just an aside. Saying goals is not the more proper way to say this. The proper language is actually target. And the reason being is because when you use the word goal, what that can evoke in someone subconsciously is that I have to reach something, and if I don't reach it, I will fail. And so it's better to set targets because then you can give a range. So people have, a range to hit versus I got to get under 7. But what if the person doesn't get under 7? Now they're discouraged because now they feel like they have failed in life. No. Okay, we're going to try to get you between a this and a this. This is my target. These are my benchmarks for you, okay? That's better language, okay? And again, I'm not perfect in it, but I am definitely actively trying, and then I'm also encouraging everyone else to do that as well. So what you'll see this approach to individualization of glycemic targets, the things you need to keep in mind: disease duration. The longer a person has had diabetes, that is a factor of what the target will be. The longer somebody has had it, they're going to have lower, it says here, long-standing, they're going to need to have less stringent goals. And so then you also have life expectancy. Again, someone who's older is going to have a less stringent goal. Risk potential associated with hypoglycemia and other drug effects. If that is a high risk, then they're going to have a less stringent goal. Important comorbidities. And in later standards, we'll talk about the comorbidities that they're talking about because they actually have a standard for them. But that is one: established vascular complications, patient preference. That is something to consider. As you're seeing, we're seeing a theme here, y'all. It says that if a patient is highly motivated, excellent self-care capabilities, that they can have more stringent of a goal. And if you can see here, it says more stringent means greater than, less than 7, and then less stringent means greater than 7%. Then resources and support. Their resources readily available to them. Do they have resources like family support? Do they have community resources? If that person can have more of a more stringent goal, because they have support to help them and resources that can help them. And so that is something to consider. We just don't throw everybody at the target of less than 7. No, you got to look at the patient and keep them center of care. We're catching a theme here. And so as far as, of course, they do give us actual, the recommendations. That's what they named them, the Glycemic Recommendations. Now, this is for non-pregnant adults, because once you get into inpatient, once you get into pregnancy, once you get into peds, and then there's some other subsets out there, you got different targets. But for the general non-pregnant adult, your A1c, they're recommending we're going to shoot for less than 7 if we can, keeping that other chart in mind. Then your preprandial, meaning before they eat. And this could be fasting, or this could be like before the meal. Their blood sugar should be 80 to 130. That is your recommendation. And then postprandial, which postprandial means 1 to 2 hours after the beginning of the meal. So postprandial would be if you ate lunch, you started eating lunch at 12, then that means 1 to 2 p.m. That's what's considered postprandial. They want that to be less than 130. And they call this the peak plasma glucose. So this is like your food has gotten in, it's in your body is responding to the food in your body. So we want that number to be less than 180. And that's the same from last year. But these are just, again, keeping in mind recommendations. They do go into hypoglycemia. Hypoglycemia is something that we must address. You can't just, when somebody tells you that they've had hypoglycemia, you have to investigate. You just have to. And there are levels. There are 3 different levels, stages of hypoglycemia. So let me run through these right quick. So level 1 is a glucose less than 70. And so this doesn't mean that they feel anything. They may not feel like they have hypoglycemia, but if you're looking at their records and you're looking at their blood sugars and they're running under 70, that's considered level 1 hypoglycemia. Level 2 is a glucose less than 54. So that's level 2. And then level 3 is anytime, doesn't matter what the number is, anytime that a person is having an altered mental or physical status, meaning that they require help to treat the hypoglycemia. So they can't help themselves. Maybe they passed out. Maybe they're loopy. Maybe, like where somebody has to give them an injection of glucagon. Now, anytime they can't self-treat themselves, they need assistance to drink something, no matter what the number is, it could be 80. If they have that, then that's considered level 3. Okay. And so, of course, they go through like the treatments of hypoglycemia. We're very, very, very much familiar with like the injection, the emergency kit there, but there's other ones too. There are different ones that are inhaled. They're not even really inhaled. You just kind of, if the person is breathing, they'll breathe it in, and then they have different dosages for your children. I want to say the only one that is like all ages is the emergency kit. I'm a little rusty on that, but don't quote me. But just know that all children can't take all of the different forms. And I want to say it is the injection that all ages can take it, like under 2 and all that stuff like that. But that's in the insert. Whatever you have, you would look in that and educate there. I think that is all that I'm going to cover. Looks like I'm freezing up over here on LinkedIn. So sorry about that if you are on LinkedIn. Sorry about that. But that's all I got, guys. That is all I have for you. Let me be honest with you. I'm probably not going to come back tomorrow because I have some things I have to do tomorrow. So I'll come back probably on Thursday. We'll do a live on Thursday, and I'll try to knock out 7 and 8 on those days. I think I will have the time to be able to flesh both of those out. But I thank you guys. Again, if you are on Instagram, but you also do YouTube, I'm Kim E, the Diabetes MP over on YouTube. I'm going live on YouTube as I'm doing this as well. Replays are going to be on every platform I'm going live on. I'm also going live, though it's frozen, over here on LinkedIn. So I'm there too as well. The Diabetes MP, you can search me, Kimberly Ellis. And, thank you guys. I will catch y'all in a couple of days. All right, bye.